The last segment today is focusing on relapsed and refractory multiple myeloma. Although we have all this progress, improved deep responses, long duration of the responses, unfortunately, most of the patients will continue to relapse. If you look at all the trials that have been developed that also now have led to NCCN guideline, they consistently have these comparisons, as you brought up, John, the inferior 2-drug versus 3-drug, and surprisingly the 3-drug seems to win all the time, but none of these trials have compared a 3-drug versus another 3-drug versus a third and so forth. The NCCN guideline, according to the present way of thinking, has put all these in the guideline, and that's correct, and the FDA approved. Do continuous treatment for all the patients is still kind of the way we do it, but maybe that's not necessary.
In the relapsed refractory.
In the relapsed refractory setting. So, Sundar, do you have a particular combination you like over the others in the, say, first relapse?
First of all, I agree there are multiple combinations available, which is very important because we just now finished the frontline setting, and we know frontline setting has also become combination, triple drug combination, and could become quadruple too, as we saw, right? So it is a very changing environment. So how the patient comes to you depends upon what their prior drug exposure, and then who is coming to you, because the patient's performance status, frailty, renal impairment, all of that has an implication. And then, you know, tumor-based, whether this is a high-risk patient or somebody biochemical remission, relapse, somebody who was on maintenance and the M spike went from 0 now to 0.2, 0.5 over a period of time. All of that plays into how you do. And moreover, the treatment choice also, the patient has an important aspect to it because they have gone into first remission, they had a good durable remission, and they have quality, and they are re-engaged in their life because initially it was a turmoil. It turned their life upside down. Now they are re-engaged their life. They are back to work, etc. Then they are interested in to minimize the amount of interruption again by the relapse and the treatment. So that is why, you know, it is not a cookie-cutter approach that I use. It depends upon prior exposure. So the availability are there. So going back to the backbone discussion, you know, we can build a backbone with an IMiD or a proteasome inhibitor with an antibody as one of the options because DVD, the daratumumab, Velcade, dexamethasone, has shown to be effective. Pomalidomide as a backbone with daratumumab and now with isatuximab, right? Any anti has been shown to be effective. Elotuzumab with pomalidomide, dexamethasone had equivalent outcome like dara, so we don't even have to hesitate which one we want to use, you know. So these are options or
and
good
also
options.
Cofilzumab, daratumumab, dexamethasone is also about to read out, but preliminary data has been from smaller studies. There was a blood paper showing excellent response
so
as well.
proteasome inhibitor with the daratumumab. And then before, you know, dara or the monoclonal antibody came, you got to remember there were drugs of putting again. Patient had Velcade before, they'll go on Kyprolis now. They had Revlimid before, they go on pomalidomide now. So you have KPD as one of the treatment also. So it all depends upon a mix. So it is very difficult for me to actually tell this is what I use. See, frontline, we can say this is what I use much more readily. But in a relapsed patient, I don't have the recipe.
But do
the recipe
you use
changes.
Revlimid maintenance on many or not so many patients?
We do
so
use
they do
Revlimid.
Relapse on Revlimid. So do you still use Revlimid in the relapse?
The relapse setting, because we have been focusing on a lot of clinical trial in relapse patient. The newly diagnosed myeloma patient, I consult and send it back to the community. So how they come back to me varies. There are patients who would have gone through transplant on no maintenance because the patient didn't want maintenance, or they were on maintenance for 2-3 months, then they had a rash or they had diarrhea and then they discontinued, then they didn't went on, or the relapse has happened a year after they have discontinued the maintenance. So the patient comes to you in many different ways.
There's a broad range of presentations.
Frontline, at least I can give you a cookie-cutter recipe. In relapse situation, you have to have some more information and insight on the patient because relapse patients are detected. They are not undetected people because they are being monitored, because they are relapsed. So you're picking the relapse a little bit earlier. So there is also so-called clinical relapse or symptomatic relapse, I should say. Clinical relapse, everybody's relapse is a clinical relapse. Symptomatic relapse, where a PET showed a lesion or something like that, or a creatinine is a little bit going up or something. And then there are asymptomatic relapse because we follow these patients and get the paraprotein level done. So all of this plays into the role.